Good evening, everyone. I'm Dr. Catherine Stewart. I'm a GP educator with the PHN in Bathurst. I'd like to welcome you all this evening to the talk on headache, workup and migraine. Would like to initially acknowledge that we work on the traditional lands of many Aboriginal clans and nations and pay our respects to elders past, present and emerging. I acknowledge their continuing connection to land, water and culture and ongoing contribution to help shape the life of communities which we all work and live on. I warmly welcome any Aboriginal and Torres Strait Islander Australians who are present in our meeting this evening. Just a couple of housekeeping things. This event is being recorded. We've actually got all the attendees on mute, so if you do have any questions, you should be able to see on the right-hand side an option there. There's a little orange arrow. You can bring it in and out to bring up the question thing and type in your questions. If it's a burning question, I'll try and put it to Emma during the meeting. Otherwise, we will have some time at the end for that. So certainly like to thank Dr. Emma Blackwood for presenting to us tonight. As I'm sure most of you know, Dr. Blackwood's a consultant neurologist and neurophysiologist who works in Orange. She grew up in Bathurst and studied medicine down at the University of New South Wales and did all her further training in the Sydney hospitals before, for our good fortune, coming back to the Central West where she services the area. So I'll hand over to Emma. Thank you.
Rightio. Oop, hang on, I've got to. Okay, hopefully everyone can see my slides. No, I've done it wrong, have I?
No, you're all good.
I can
I'm
see
all good.
Emma.
Okay. Excellent. Okay, so we're going to talk about headache today. It's obviously a pretty big topic to try and cover, so try and cover bits of it. So why am I here to talk about headache? Headache is incredibly common. It's a really debilitating disorder. And it's actually the leading cause of neurological disability in Australia, just because of the number of people that suffer from it. It's estimated that up to 4.9 million Australians suffer from migraine, and these numbers are from 2016, so they've increased since then. But it costs the health system $14 billion a year and the economy at least $35 billion a year. So it's a pretty big problem. And I'm sure a lot of you will see a lot of headache patients. And as one of my mentors told me when I was training, you're going to see a lot of headache patients. So you figure out how to approach it and hopefully you can enjoy it, because otherwise you're going to be miserable for most of your day. So good to figure that out. So in terms of the outline of this talk, I'm going to talk about how I approach a patient when they come in with headache. And the main question there is it a primary or secondary headache? And do they need further investigations or imaging? And then I'm going to focus the rest of the talk on migraine. Migraine is the most common primary headache disorder, and it's probably the main one we'll see. And so there's been some recent advances in the treatment of migraine, particularly in the preventive options. And so I thought it'd be good to do a bit of an update about those things. So the real question when someone comes in with a headache is this a primary headache or a secondary headache? And everyone is always worried about, am I missing a brain tumor? Highly unlikely. 90% of patients that I see have migraine or another primary headache disorder, and it's probably very similar in GP clinics. So most of the time you are looking at a primary headache disorder, but you need to have an idea about which patients don't have a primary headache disorder and what to do about that. So as with many, many things in neurology, it's all in the history. Not much of it you'll get in the examination or the investigations, and it's all about asking the right questions, asking about their current headache features and the time course of them, exacerbating relieving factors, any associated symptoms, trying to get a past headache history out of them. And I often find that's interesting. You know, they go, oh, no, I don't get headaches in the past. And you say, you probe them a bit further. You know, an older woman, for example, you say, did you used to get headaches when you got your period? Oh, yeah, I always got headaches when I got my period. I thought that was normal. So sometimes you have to obviously ask them a bit harder. In terms of the examination, again, there's not a lot. Do they have any sort of focal neurological deficits? Always checking their blood pressure. Do they have any systemic signs? Do they have a fever or anything else that'll suggest an underlying condition? And then fundoscopy is the other important thing to do there. So as I said, most patients with who come in with headache will have a primary headache disorder. Migraine is obviously the biggie in there, and then tension type headache. And then the next big group are the trigeminal autonomic cephalalgias. So cluster headaches, the big one in there, paroxysmal hemicrania, hemicrania continua, etc. And then there's other rarer primary headache disorders which you may not see very often. But having a handle on migraine and probably cluster are probably the main ones to really have a think about. So when you're thinking about secondary headaches, there's always a mnemonic for everything in medicine. So this is the mnemonic to look into thinking about secondary headaches. So it's SNOOP4. So the S stands for systemic signs or symptoms or secondary risk factors. So do they have an underlying problem such as HIV or cancer? Do they have a fever? To suggest meningitis, weight loss, all of those questions. N is, do they have a neurological deficit? Now, remember, migraine can have focal features in the aura phase of the migraine, but if they've got other neurological deficits, obviously you need to think about a secondary headache disorder. Then there's a few O's. So O, the onset being more than 50 years old. Most patients over 50 will still have a primary headache disorder, but it is rarer to get the onset of a primary headache disorder after the age of 50. So the things that you really need to think about if they're more than 50 year old are obviously polymyalgia rheumatica, temporal arteritis is the main one there, and stroke is the other thing to think about in an over 50-year-old. The other O one is onset is thunderclap. So does it reach its maximum in less than 60 seconds? Because obviously that you need to think about subarachnoid hemorrhage and all the differential for thunderclap, and they should obviously be going to the emergency department for further workup. Then the P's, so the first P is for papilledema, which is obviously important to look for features of intracranial hypertension. The next one is pattern change or progressive headache. Is this their usual headache disorder, or is there something different about it? Is it changing? Has there been a significant change in the pattern for that? Then the next P is it precipitated by exercise or Valsalva manoeuvre? So certainly migraine will worsen with exercise, but it won't come on with exercise. And then the other big one is postural aggravation. So asking them, is the headache there when you, does it go away when you lie down completely, which might be a key towards intracranial hypotension, or conversely the opposite? Is it there when they wake up every morning, in which case you're thinking of intracranial hypertension? So that's sort of the main ones to think about, and that's certainly been validated in a couple of clinical trials in the emergency department. So they're the sort of main questions I usually try to ask my patients. Oops, sorry, back over there, whoops. So in terms of investigations, as I said, there's not usually a lot of investigations that are particularly helpful in headache disorders. Obviously, if they're more than 50, you need to think about that temporal arteritis, as I was talking about, so ESR, full blood count. If they've got any systemic signs or symptoms, they'll need some blood tests. And then I guess if they haven't had a basic range of investigations, such as looking for anemia or thyroid disease or anything with a new onset headache, it's obviously reasonable to do them if they haven't had it done recently. In terms of imaging, as you know, MRIs are now available for chronic headaches, and certainly they have a much better utility than a CT scan for chronic headache disorders. So if possible, it's obviously much better to refer them for an MRI scan. And we're pretty lucky here. You know, there's 3 MRI scanners in Orange, there's now 3 in Dubbo, there's 1 in Bathurst. So there's fairly good availability of MRI scans in the local region. And certainly they'll show up a lot more than CT scans for chronic headache. The CT brain, I think, is useful if they've got a focal signs or they've got an acute onset headache disorder and you're worried about more acute things, then certainly get a CT scan in that stage. But certainly for chronic headache disorders, it's not usually useful. The other useful thing, I'm not sure if I said yet, in terms of the examination, certainly fundoscopy is obviously a very important thing to do in headache. But if you're not sure about the fundoscopy, then the good thing is we've all got optometrists locally. And certainly they can do a full review looking at visual fields, looking in their fundi, doing an OCT. So certainly if you're worried that someone's got a chronic headache and they may have intracranial hypertension and you're just not sure, then it's obviously quite simple to send them to the optometrist who can do the visual fields, and the OCT, which can be really useful for making sure it is true papilledema. So I thought now we'd have a look at a couple of cases, and we're going to have a bit of a poll after each case to see if everyone thinks it's a primary headache disorder or a secondary headache disorder. Certainly give it a stab, see how you go. So case one, this is a 66-year-old man who came to see me earlier this year. He came in with a 2-week history of headache. He couldn't really remember how it started. It was kind of just this bilateral occipital location radiating the frontal region. It was gradually getting worse over a couple of weeks, and by the time he came to see me, it was getting pretty debilitating in nature. It was throbbing, there was a bit of nausea with it, but not really photophobia. And he really didn't have a significant past headache history. He's got a bit of COPD, bit of reflux, bit of arthritis, so there is usual medications there. Had a completely normal examination. So we're going to, the question is when he comes up, does he have a primary headache or a secondary headache? So if everyone wants to give a go at, I can put, no, can't put that back on at the moment. So 66-year-old, new onset headache over the last couple of weeks. I can't see. Excellent. Most people think he's got a secondary headache disorder. So there's certainly a couple of clues there. Certainly, first of all, his age. Secondly, it's a progressive headache disorder. It's been coming on over a couple of weeks. And what I didn't tell you was when you probe him a bit more detail, I said, you know, does the headache go away when you lie down? And he said, oh, it doesn't particularly 100% go away, but certainly when it first came on, it did go away when he lay down. So, okay, so this is his MRI scan. He had a CT scan. I couldn't find the pictures. This is his MRI scan, which shows a bilateral subdural fluid collections. As you can see there, kindly measured by the radiologist. And this is his, I sent him back for another MRI scan with contrast, which is showing enhancement of the pachymeninges. So he's got a spontaneous intracranial hypotension with a spontaneous CSF leak, which we're still trying to track down the exact site of the CSF leak. But certainly, yeah, he's one that obviously needed to have neuroimaging done. So case number 2. This is a 40-year-old male smoker. He comes in with a 2-week history of headache. He's having 3 headaches per day. They're even waking him from sleep at night, usually around 2 o'clock in the morning. It's a severe headache. It's located around the right eye, and it lasts about an hour in duration. When he's got the headache, he's pacing around the house. He's really agitated. He's got a watery eye and a runny nose on that same side as the headache. So, does this man have a primary headache or a secondary headache disorder? Excellent. Most of you are able to recognise that this man's got a cluster headache. So certainly, as you know, it commonly occurs in males who are smokers, and that typical story of headache a few times a day with those autonomic features. Now, migraine can occasionally have autonomic features. One of the things that it's classical for cluster headache is that agitation. They're pacing around the house. Sometimes they're even punching walls because it's so severe. And it's a pretty important one to recognise because they call it the suicide headache. It's incredibly debilitating. So certainly if you've got a patient coming in like that, certainly happy to be contacted and we'll try and get them in to be seen pretty early because it's an incredibly debilitating type of headache. They do need imaging, but certainly referral on pretty early is pretty useful thing to do there. Okay, oops. Okay, case number 3. This is a 22-year-old female. She comes in with this headache that's gradually getting worse over the last few months. She used to get headaches every so often coming on with a period. It's a pressure-like pain that's around her whole head. She's got a bit of nausea, a little bit of visual disturbance, and when you ask her, she's got a pulsatile sort of whooshing sound in her ears. So, what do we think about her headache? Yeah, so there's a bit of a divergence there, but again, most people are saying she's got a secondary headache disorder. And certainly I didn't give you the big pointer in the examination, but you had a look in her eyes and you saw that. So as you can see there, there's some optic disc swelling, some papilledema there. So clearly once you looked in her eyes and found that, you'd know that this is a secondary headache disorder. The other feature on this one that would tell you that's the secondary headache disorder more likely is the progressive nature of it. It's certainly, she used to get intermittent what sound like migraine headaches, and then it's just getting worse and worse over the last few weeks. It's becoming more frequent. Now that could easily also be migraine, but certainly once you look in her eyes, you know it's not. And certainly this patient would need an MRI scan of the brain, and certainly she should obviously be referred on as well for further management. As she's probably got into idiopathic intracranial hypertension, which certainly occurs in young overweight females, so certainly one to watch out for. Okay, so case 4 is another young woman. She's 24. She's got a 5-year history of intermittent headaches. They occur a couple of times a month. They're usually on one side of the head in the temporal region or the occipital region. They're throbbing, they're moderate to severe in intensity. She has a bit of nausea, she's a bit sensitive to light, prefers to go and lie down in bed when she's got these headaches. And they last up for a few hours, up to a day or so in duration. She has a normal examination, including fundoscopy. So what do we think about this headache? Excellent. Most people seem to recognise this as migraine. So you guys all seem to be experts on headache already. So probably you'll know what I'm about to tell you. So as you probably know, all of these types of headache, there's this book called the ICHD-3, which basically has the diagnostic criteria for all the headache disorders within it. And so this is what it says for episodic migraine: 5 attacks, headache. It has to have at least 2 of the following 4 characteristics: unilateral location, pulsating quality, moderate to severe pain, aggravation by or causing avoidance of routine physical activity, and then they have to have at least 1 of nausea and or vomiting, photophobia and phonophobia. And it always has at the bottom of all of these ICHD-3 things, not better accounted for by another diagnosis, which is not particularly helpful. So the interesting thing, I saw a patient today who said, oh, I've got these headaches. And she said, but they're not migraines. I said, why aren't they migraines? She said, oh, look, I've had 2 migraines in my life. They were debilitating. I was vomiting. I went to bed. These are different from those. And then she went on to describe this headache that was on one side of her head. It was throbbing. It was moderate intensity. She was a bit sensitive to light, a bit sensitive to sound. And I'm like, it's a migraine. People seem to think that a migraine has to be a 10 out of 10, worst headache of their life, put you to bed, vomiting and things. But certainly, like most things, there's certainly a spectrum. So most of the time when I see a headache patient, my presumption is that it's 90% likely to be migraine, and I'm certainly asking them frequently about these questions. You say, oh, you're sensitive to light. They're like, oh, no, the light doesn't bother me. And they're like, well, if you've got the headache, would you prefer to go out and out in the sunlight, or do you want to lie down in a dark room? And they're like, oh, no, I want to lie down in the dark room. And you ask them, do you have nausea? Oh, no, I don't have nausea. And I'm like, well, but do you want to eat do you have a loss of appetite? Oh, yeah, I've got a loss of appetite during it. So sometimes you have to sort of pull these features out of it, because they won't necessarily volunteer them, or they'll say, oh, no, and then you'll probe them a bit further and they actually do have those features. So I'm going to move on to migraine, as I said, because migraine is certainly the most common of the severe headache disorders you'll see, and it's always good to have a plan of attack. So when I see a patient with migraine, the first thing is that I educate them that, yes, this is migraine. Certainly it's fulfilling all the features of that. Yes, it's debilitating. No, you don't have a brain tumour. No, there's nothing in particular that else is causing it. It's usually genetic. Then the next things are effective acute therapy, figuring out whether they need preventive therapy or not. And it depends a bit on the person, but certainly if they've got more than a couple of migraines per month, and particularly if they're not effectively treating them with acute treatment, so they're missing work days, they're missing time with social activities and things, then certainly you want to start preventive medication reasonably early. And then the third thing in there is avoidance of medication overuse headache. So Certainly, I give all of my patients a handout about the lifestyle factors in migraine. Now, as a lot of you will know, they don't make a huge difference. You don't necessarily cure your migraine with these lifestyle factors, but certainly if people are doing everything wrong in terms of their sleeping patterns are all over the place, etc., then it certainly can make a difference aiming for, improving the lifestyle factors. And certainly, all the GPs out there, you're experts in lifestyle medicine and things. So certainly the Headache Society has these free downloads on there. So this one, all of this comes from the Lifestyle Management of Headache PDF. So sleep, obviously diet, hydration, caffeine. Certainly some people are more sensitive to caffeine than others. And certainly caffeine in the acute phase of migraine can be helpful. But the studies suggest if you have more than 200 milligrams per day on average, it can increase your headache. So certainly, I had a woman today that told me she had 7 Coca-Colas a day or something, and she said, maybe you should cut that down a bit. There's certainly very good evidence that exercise can help migraines. Again, it doesn't really matter what. There's a little bit of evidence for yoga, but anything that people can actually do regularly. Ergonomics and environmental triggers can have a bit to play in it. And then there is some evidence for some supplements, magnesium, riboflavin, and CoQ10 are the main 3. And you can certainly get them in a combination thing called Migraine Care, which I think is from Bioceuticals. Again, I usually recommend people try it for a couple of months, and if it's not making any difference, then they could drop it out. But if it is making a difference, it's unlikely to give them many side effects. Certainly, there's a little bit of evidence for massage, physiotherapy, and acupuncture. Again, it's obviously hard to do the clinical trials for those things. If people feel they're beneficial, certainly they can continue with them. Interestingly though, a lot of patients come in and they say, oh, my neck's triggering off my migraines. I've got this really stiff neck. And it's actually the prodrome to the migraine includes neck stiffness. So it's usually actually the migraine triggering the neck stiffness as opposed to the neck causing the migraine, although occasionally it goes the other way. So I also give all of my patients a headache diary. This is the headache diary. Paul Spira, who's a neurologist in Sydney, came up with this one. You can download it from the Headache Society website as well. I really like this one because if you give people something that's too onerous, they won't do it. This is good because it's got the whole year on one page. It's got clear instructions down the bottom, circle when you've got a headache, underline when your period is, etc. And you can see very quickly, are you winning or are you losing? Certainly some people like to use an app. There's a good one called Migraine Buddy, and some people use other systems. But I certainly find if it's too onerous, if it's asking you too many questions, people will stop doing it. Whereas this one, you just stick it on the fridge, and every time you've got a migraine, you just circle it there. And it's very useful because you can tell very quickly how often are they getting them, are there any clear-cut patterns, how much problem is it causing in their life, and are they responding to any treatments? You certainly can put in there when you start different treatments, and you can see quite quickly. Otherwise, I find when patients come back, I had one today, how often do you get a migraine? Oh, well, I had one last week, and then the one before that was sometime in July. And, they can't really remember, which is fair enough. You don't want people focusing on their migraines all the time, which is why a headache diary like this is incredibly useful. So after I've talked about those things, then we start to talk about the treatment. So in terms of acute migraine treatment, there's very good evidence that any of the treatments for migraine work best if they're taken within that first sort of 30 minutes of the migraine attack. If you wait until the migraine is fully established, then nothing works. And so certainly sometimes you get people come in and say, oh, I tried this for my migraine, but it didn't work. And then you've got to probe them, well, when did you take it? And they might be taking them at the wrong time. So certainly that's also the problem of the middle of the night migraines. By the time you wake up with your full-blown migraine, you've missed the boat in terms of taking it. Now, most of treatment of migraine is very much trial and error approach, both with the acute and the preventive treatment. And so you tell people to try something out for a couple of migraines. If it doesn't work, move on to the next one. So certainly non-steroidal anti-inflammatories are often where it's useful to start. Ibuprofen doesn't really do much. Paracetamol does less. Good old aspirin, dissolvable, is really, really helpful for a lot of people with migraine and obviously quite well tolerated. In terms of the other anti-inflammatories, Voltaren Rapid or diclofenac can be quite useful, kicking in reasonably quickly. And naproxen can be useful as being a slightly longer acting anti-inflammatory. The next step, if the anti-inflammatories aren't doing enough, is adding in an antiemetic. I usually start with metoclopramide if people can tolerate it. A couple of reasons there. when people have a migraine, you actually have gastric stasis. So you take medication, it just sits there in your stomach and doesn't move. So the metoclopramide is prokinetic. It'll push the other medications along to get absorbed. And it also obviously has anti-nausea and anti-migraine effects. If they're getting central effects made really sleepy from the metoclopramide, then domperidone or Montilium's obviously useful. Stemetil is also useful. And then if people are really, really nauseated, then certainly on Dansitron can be helpful. But as it sort of slows the absorption of other things, I try and use the other ones first. Again, you know, everyone's an individual, so what works for one patient might not work for the other patient. Certainly adding in caffeine at that situation can sometimes be useful. So Panadol Extra, or some people will have a Coke or a espresso. Again, it's usually well tolerated. The concern there is, of course, if they're doing it all the time and then they're overusing their caffeine. If the non-steroidal anti-inflammatories and the antiemetics aren't doing enough, then obviously adding in a triptan is still the next step to use. So there's the 5 different triptans available in Australia: Relpax, Maxalt, Imigran, Zomig and Aramig. In terms of which ones are useful, certainly Maxalt, the wafer one, rizatriptan wafer, I find is a less strong triptan. So certainly if people are getting side effects from triptans, then they might find the Maxalt better tolerated. And certainly if they've got severe nausea and can't get down a tablet, it's usually quite a good one. But otherwise, as I said, it's not usually quite as strong. So certainly Relpax or elatriptan 80 milligrams or sumatriptan 50 milligrams are certainly on the stronger end of the spectrum. And then certainly if they can't get orals down, then you've got the intranasal or the subcutaneous formulations of sumatriptan. Again, they work best if taken early on in the headache, and they may not necessarily terminate one that's later on. Naramig or naratriptan has a longer half-life than the other triptan, so it's often got less side effect profile. And if someone's finding a triptan effective, but then it's wearing off after a couple of hours, then naratriptan can be useful there. For some reason, it's still on an authority script though, so it's a real nuisance. So I usually try and use the other triptans first. Now, the caution with the triptans, which is the tricky part, is making sure they're being used less than 10 days per month to avoid medication overuse headache. It'll always come up with a warning, about SSRIs, but in practice, the risk of the SSRIs and the triptans interacting with each other is minuscule. Certainly you warn people about the symptoms of serotonin syndrome, but in practice it really doesn't seem to happen. If someone comes in and says, oh, the triptan's working, but then the headache tends to come back in a couple of hours, there's certainly synergism between the triptans and the anti-inflammatories. So certainly adding in a triptan plus an anti-inflammatory, or as I said, using naratriptan, which has a longer half-life. So often my patients will end up being prescribed a cocktail to be taken at the beginning of the migraine, but the aim then is to terminate the migraine and then they can get on with their life, as opposed to chasing it for a day or two with other analgesia. So you actually end up sometimes taking less medication overall if you treat it effectively early on. The triptans, as I said, they're best taken in the early. So as soon as you know, oh, this isn't an ordinary headache, this is going to be a migraine, that's when you need to put the triptan in. So, so this patient who we were seeing before started on the lifestyle measures. She's taking aspirin and metoclopramide at the headache onset, which is working, and she's using elatriptan for the more severe headaches. So that's pretty good. It's having moderate effects, so she's still having getting a bit debilitated, and sounds like she's having about 3 to 4 migraines a month. So she's happier, but she's still not, doing as well as she could be. So this is the stage at which you need to think about preventive medications. Certainly, often preventive medications are left a bit late in the course, and it's often, if people are failing their lifestyle measures and they're still needing their acute medications relatively frequently, then certainly I often add in a preventive early on, with the aim of reducing the frequency and severity of their migraine attacks so they don't need to take so many acute medications, and hopefully stopping them from developing into getting chronic migraine or high frequency episodic migraine. So the nuisance part about all the preventive agents is, it is a trial and error approach, and they don't work straight away. All of the preventive medications can take 2 to 3 months to have their full effect once you get them up to their standard dose you need. So generally what happens is you started at a low dose and then you keep titrating it upwards until they either start to get side effects or they get to that maximum tolerated dosage. And then you stick at that dosage for 2 to 3 months, and see if it works. Obviously, if they're getting significant side effects, then they can stop it earlier than that. But it's not infrequent. I see someone came in, oh, look, I tried propranolol for a week or so and it didn't make any difference. And so, well, of course it didn't make a difference. You're only on it for a short amount of time. So certainly there's a big long list of preventive medications. I've got them on the next page. Certainly the therapeutic guidelines, if any of you have access to them, are obviously really useful with all of these medications in there. So in terms of medications that I like using, if someone has hypertension, then that's helpful because you've got a few options there: candesartan, verapamil, propranolol. If they're obese, you obviously want to avoid sandomigrane or pozotafen and consider topiramate. If they've got anxiety, certainly propranolol, amitriptyline, venlafaxine are useful ones. If they've got insomnia, then I often start with low-dose amitriptyline because obviously sleep and migraine go along well together. So in terms of the preventive agents, as you know, there's the antidepressants. So amitriptyline, really useful one if they've obviously got a lot of sleeping issues, and it's quite individual, the dose that people respond to with amitriptyline. If amitriptyline's helping but they're really sedated, then obviously nortriptyline can be useful. Of all the newer antidepressants, the only one that's really got any good evidence for migraine is venlafaxine, and it seems to be particularly useful for patients with vestibular migraine. In terms of the antihypertensives, I'm using a fair bit of candesartan these days. There was a very good study that said it's the best tolerated of all the oral agents. It's the one that most people are likely to remain on at 12 months. And even in young women with lowish blood pressure, they can often tolerate between 4 and 8 milligrams of it at night time, going up to a maximum of 32 milligrams. Verapamil occasionally, propranolol occasionally. Topiramate obviously is quite hit and miss. Some people, it's usually very effective, but obviously quite a lot of people get side effects from it. Tingling, anxiety can be a significant issue with that, and the cognitive effects at higher doses. So it's really quite hit or miss. Sodium valproate, used very occasionally, but obviously the teratogenicity and the other side effects of it are limiting that a bit. And then sandomigrane, you still find a patient that tolerates that reasonably well. Obviously need to watch for the weight gain with that medication. So they're the main sort of oral agents that I tend to use. So she comes back 4 years later, headaches are going up. She now has a headache more days than she doesn't. About 8 days per month is similar to previous, and about 10 days per month, it's a dull bilateral, just a tension type headache. So unfortunately, she's got chronic migraine. So chronic migraine is a very big problem, as you probably know. So headache more than 15 days a month. And interestingly, a lot of the patients you see with chronic migraine go, oh, no, it's not a migraine, because it's not that 10 out of 10 migraine they used to get when they've got episodic migraines. But it's still, it's still got all those migraine features in that it's on one side of the head, they're a bit sensitive to light, a bit sensitive to sound, it's throbbing. And so they're meant to have that on more than 8 days a month. So it's a bit of an arbitrary cutoff between, do you have migraine less than 15 days a month or more than 15 days a month? I often find a better question for the patients is, how many days a month do you have a clear head? And they go, oh, I don't have a clear head. I have a headache every day. I just didn't mention the less severe ones. So it's often a more telling question. Do you ever not have a headache? Oh, no, maybe once in a blue moon I don't have a headache. I just have a headache all the time that I live with. So chronic migraine is obviously a big problem. So preventive medications, hopefully you've instituted them even before they get to chronic migraine, but definitely if they've got chronic migraine, avoiding the medication overuse headache, and then obviously considering the newer therapies which we now have available for chronic migraine. So the injectable therapies, botulinum toxin injections and the CGRP antibodies, which have only come out recently and you've probably started seeing in clinical practice. So these both have the same PBS criteria. The patients have to have chronic migraine, as in they have more than 15 days of headache a month with 8 days of migraine. They have to either had an inadequate response, an intolerance to, or a contraindication to at least 3 of the prophylactic migraine agents as listed there. They have to be appropriately managed for medication overuse. They have to be adults over 18, and both those things have to be initiated by a neurologist. So certainly if someone's got chronic migraine and they're failing the preventive therapies, definitely refer them on. In terms of ongoing treatment, they're both given for a trial period, and then if they qualify, they can keep using them. So Botox, obviously botulinum toxin's been used for quite a few years for migraine. Pros and cons is it's obviously a local treatment, so it doesn't have systemic side effects. It's effective in about 70 to 80% of people with chronic migraine, interestingly not in episodic migraine or tension headache. The two nuisance parts about botulinum toxin are, number one, the number of injections you have to give. So you tell a patient, oh, I'm going to do 31 injections in your head and your neck, and they sort of look at you like, the whole thing takes about 5 minutes. It does sting a bit. And then the main downside is it wears off every 3 months, after 3 months, and most patients end up needing to come back every 3 months. The PBS criteria state that we can only inject it every 12 weeks, and a lot of patients find it's wearing off a bit earlier than that, but we're certainly got our hands tied a little by the criteria. So the new thing on the block, obviously, for chronic migraine are the CGRP antibodies, of which Emgality, that picture of the injector up there, is one of the two that are now available. So CGRP stands for calcitonin gene-related peptide, and it's been known since the 80s that CGRP is elevated when people have migraine, and the Triptans block the CGRP from being released. So these drugs are monoclonal antibodies that block CGRP. They physically bind to the CGRP and stop it from binding to its receptor. There's 4 of them, and they all came out at the same time, and 2 of them are now available on the PBS. Emgality, or galcanezumab, and Ajovy, which is fremanezumab. And they're both given monthly via subcutaneous injection. At present, Emgality is an auto-injector, as you can see up there, and Ajovy is a pre-filled syringe for subcutaneous injection. So for that reason, Emgality certainly has a slightly bigger market share because people would prefer to use the auto-injector usually. They seem to be effective in about 60 to 70% of patients with chronic migraine. 10% of people get a dramatic response where they never have a migraine again. And then 60 to 70% get that 50% improvement that will allow them to keep using them. And they're tried out for an initial 3 months. Often they start working even in that first week or two, and then the responder rates certainly increase out to that 3 months. So usually I tell people to keep going with them for the 3 months if they can. There's relatively few contraindications. So CGRP doesn't seem to be important for much else in the body, which is helpful. It is on blood vessels, so it's contraindicated if they've had recent cardiovascular or cerebrovascular events. And there is a slight concern of increasing hypertension with CGRP being blocked for a period of time, so certainly their blood pressure needs to be monitored. And it hasn't been trialled in pregnancy or lactation as yet. They're very incredibly well tolerated agents. It's very rare you get anyone coming back with side effects, but certainly the main side effects, as you can imagine, are injection site reactions, a bit of nasopharyngitis, and constipation, which is a little bit more with Emgality rather than the Ajovy. They certainly are also effective in episodic migraine, unlike botulinum toxin, but they're only on the PBS for that chronic migraine. So again, that's where the headache diary is really helpful. You want to see that someone has more than 15 days of headache a month, and then hopefully going down to less than 7 or 8 days of headache a month after they've been on this treatment. They do act synergistically with Botox, but you can't get the both of them on the pharmaceutical benefit scheme. So if someone wants to use it with the Botox, or if they've got episodic migraine, they certainly can have them on a private script from about $280 per month. The other really nice thing about these medications is that they're not immunosuppressors. So whilst they're a MAB, they just physically get in the way and block things. So they're not an immunosuppressive agent. So in the age of COVID, there's certainly no concerns there. And really, there's no monitoring required for these agents. They've now been around for about 5 years. And certainly we haven't had any concerns about long-term side effects as yet. So they're a pretty exciting drug. And certainly there'll be more and more patients on them. In the PBS, it says that they have to be instituted by a neurologist or under the supervision of a neurologist. So certainly I will start the patients, but certainly if they're doing really well, I figure I don't really need to see them back every 6 months, maybe every 12 months or so, just for a review. So she comes back, she's tried the amitriptyline, she stopped it because she was a bit sedated, she tried the propranolol, she didn't think it was working very well. So now she's got a headache, which is there every day, and she's taking paracetamol every day, and she's taking a lot of codeine. Luckily, this doesn't happen so much anymore now that codeine's not over the counter, but certainly you still sometimes see patients with this. And this is obviously medication overuse headache. And medication overuse headache is a real problem because certainly what happens is they're taking these medications. So opioids, triptans, ergots, more than 10 days per month. Even paracetamol more than 15 days per month can cause medication overuse headache. For some reason, it tends to only really happen in patients with migraine or tension headache. Seems that people with cluster can keep using these triptans quite frequently and not run into medication overuse headache problems. Now, the issue with medication overuse is you only know they've had it is when you get them off the medication and their headaches improve. So it's a really difficult one to do. The studies have shown that it's best if they can cold turkey the medication. Obviously, that's difficult for people to do. And obviously, starting the preventive medication at the same time will help them come off the other medication and obviously treat their underlying headache disorder. In terms of bridging therapy, if people can't cold turkey it, then certainly naproxen slow release can be useful for a few days. Otherwise, sometimes I use a bridging course of prednisone if people really can't get off their acute medication. So 50 milligrams daily for 3 days and then slowly weaning it. Those are also in the therapeutic guidelines, which are useful. So you weaned her off the codeine, got her on some dopyramate, and she's doing quite well. She still has a migraine per month, and it's usually 2 days prior to the menses. So just a couple more slides and then we'll be done. So she's getting this migraine and it comes on, you look at a headache diary and it's 2 days prior to a menses. So why does this happen? As you can see here, it's a graph of the menstrual migraine, and there's 2 main reasons why people get a migraine with menses. Mainly it's the estrogen withdrawal, that's the migraines that happen in the day or 2 prior to migraine, and then it's the prostaglandin release during menstruation that can also trigger migraine. So you can see this graph here showing that migraines are much more likely to happen around that menstrual cycle. And certainly perimenopause is another time they often start to flare up as well. So if people are getting menstrual migraine, the headache diary, as I said, is very useful. If they've got a really regular cycle, then short-term prophylaxis with either naproxen or even naratriptan can be useful. If their cycle's all over the place, then obviously it makes it a bit more difficult, and often you need to just put them on a regular preventive agent. Certainly if they don't have aura with their migraines, you can consider a continuous oral contraceptive pill so they no longer have that estrogen withdrawal. So the last case I wanted to do very, very quickly is this is something that I'm seeing relatively commonly these days, and it's a useful thing to know about. So this is a 40-year-old woman who comes in. She's got episodic vertigo. She gets these frequent attacks of vertigo. They're either provoked by movement or they're unprovoked. She says, I'm just sitting here and it feels like the world moves. It's quite debilitating for her, and it's happening quite frequently. It lasts anywhere between minutes to hours. She says, I don't have any other tinnitus or blocked ear or any of those other symptoms to suggest Meniere's disease. She's a bit sensitive to sound during it. And she sometimes gets a little bit of a headache with it, but the headache's not really anything to complain about. She does have a history of episodic migraine with aura. So what this is vestibular migraine. So the funny thing about vestibular migraine is that it doesn't have to happen with the migraine. You can get the vertigo at all types of other times, and it doesn't have to have the migraine at the same time. If it does have the migraine at the same time, it's really useful because it obviously helps you make the diagnosis, because again, there's no diagnostic test for this. But they did a study at a tertiary dizziness clinic in, I don't think it was in Sydney, but I can't remember. And they found that BPPV, or benign paroxysmal positional vertigo, was the first most common cause of vertigo, but the second most common cause of vertigo is actually vestibular migraine. And that's because migraine is such a common disorder. And for some reason, it often does tend to happen sort of in people around their 30s and 40s. And certainly partially having an explanation for why they're getting vertigo can be quite helpful. And then also in terms of treatment, if they're having it really frequently, then certainly using preventive medications for migraine can be really quite useful in terms of reducing their attacks of vertigo. So it's certainly something to think about when people come in with vertigo. And I think that was probably my last slide. So, and I think we're pretty much on time now. And if anyone's got any questions, I hope I didn't rush through all that too quickly. Catherine?
No, that was excellent. Thank you, Emma. I certainly learnt a lot. So if anyone does have any questions, I can't see any there at the moment in our question box. Oh, yes, someone has one. Yep, do you want to type what it is? You'll have to type it. We can't unmute you. Sorry, Chris. Now, someone asked if you do telehealth referrals.
Yeah, we certainly have been doing a fair bit of telehealth. I find for new patients, I prefer to see them in person if possible, but certainly if it's not possible, doing it via telehealth. And as you guys know, the rebates for the phone consults are pretty much gone. So they need to have a reliable internet connection to enable Zoom or something like that. And certainly for the follow-ups, I'm doing a lot of telehealth because it's obviously a large geographic area and it's quite difficult for patients to come all the way here. Certainly if they've had an MRI scan and someone good's looked in their eyes, they're probably the two main things you need to do for migraine. Then certainly an initial consult could be done by telehealth as well.
Yep, thank you. So a little bit of questions back on that last case. Tess has just asked, you can put the slide up again that was before the last case study 4 slide.
Oh, before the case, this one? No. Which one?
So it must be before the case study 4 slide. Do you want to just, it had medications on it.
Oh, the preventive medications.
There.
That one?
Is that the right one? Tess, yes, thanks from Tess there.
Yeah. So certainly hopefully these slides will be available for you. And certainly I've basically just copied that straight out of therapeutic guidelines. If you've got access to them, then it's all in there.
Yep. So there's a few questions coming through with regards to the migraines with the oral contraceptive pill, particularly, you know, and we all have some, the patients who do get aura, but they really, really want their contraceptive pill.
Yeah, so certainly, as we all know, there's a contraindication for migraine with aura with the oral contraceptive pill because of that increased risk of stroke. Now, certainly most of the data of that comes from the old oral contraceptive pills with the 50 micrograms of estrogen in them and not the newer formulations of contraceptive pills. And so I guess there's probably slightly less risk there. But certainly once you've seen a young patient with a stroke, you want to avoid it as much as you can. So my take on it is certainly if someone has a really good reason they need to be on the contraceptive pill, such that they've got endometriosis or something like that, then certainly I think there could be a role for it there. If it's for contraception, then certainly I think there's enough other options these days, you know, Implanon, Marinas, those sorts of things that are probably a much better option and a lower risk than progestogen only options. And certainly it's better to avoid the estrogen ones if you can.
Thank you. So just a question here from Chris. Is there any evidence for additive effect of the prophylactic medications? So using more than one?
Yeah, look, I think again, the clinical trials have only single agents. And certainly I sometimes do use that. So if someone comes in and they say, look, I'm on topiramate and it's having a medium effect, but and you certainly try and push the dose up, but they get too many side effects, then I might leave them on that and add in another agent. Similarly, I might leave them on a low dose of amitriptyline if someone is finding it quite helpful with their sleep, and then add in a second one. Often I'll try and then wean off another one if you can, so they don't end up on too many medications in the long term. But yeah, pragmatically, you often do end up, you know, adding medications together and for the different side effect profile and different mechanism of action. So certainly they might be on one antihypertensive and one sort of antidepressant or one anti-epileptic. And certainly when I start my patients on the CGRP antibodies or Botox, for that first 3 to 6 months, I usually leave them on their oral treatment because you want to have the best chance of those new medications working so that they can qualify for it. And then if they do seem to respond to those newer medications, then I will slowly try and wean off the other medications, as long as everything in their life is going well at the time. You don't want to rock the boat too much if they've got too many other issues going on.
Thank you. There are a couple of questions about children with migraines, if there's any specific sort of considerations, and do you have any comment on sort of prophylactic medication for children?
Yeah, so as you know, I'm an adult neurologist, so I try to avoid seeing children as much as I can. I tend to see them from about the age of 15. I think like with a lot of things, it's hard to do the clinical trials in children, and actually a lot of the medications actually have negative trials. Certainly the lifestyle things are important initially, making sure they're getting enough sleep, particularly in that teenage population. I think medications, they sometimes use propranolol, periactin is sometimes used, amitriptyline. I think they're the only ones with actually any evidence in children. I've very occasionally used Botox injections in a 16 or 17-year-old. But yeah, in terms of the younger children, certainly I don't have expertise in that area.
Now, someone did ask about the riboflavin in children.
Yeah, I wouldn't be able to comment really, sorry.
That's fair enough. Just going back to the pill, someone did just remind us about the new progesterone only, the Slinder.
Oh, is that going to be available in Australia now, is it?
It is currently available, it's just not on PBS.
Yeah, so that would obviously be a useful option if people can, because it's the estrogen component of the pill that's the issue.
Yeah, so it's a good option. I've got a question here from Deepali, which is, what about headaches associated with dry eyes syndrome? Do you want further clarification on that? Sort of.
Yeah, I'm not really sure what she's getting at there, to be honest.
Yep. So if you've got sort of more questions about that, please add that in. Just another one here. So if someone's going cold turkey from their medication overuse headache, how long before we sort of know, that
I think the studies show that it's sort of that first 5 days to a week or so. I think codeine's worse than the triptans, but it's round about that period of time that actually their headache can get worse, and then they'll start to turn the corner. Yeah, so that's why using that bridging therapy for about a week or so is quite useful. The useful thing about cold turkey, I think, first of all, the study showed that the medication overuse headache got better more quickly. And also, if you say, oh, try and reduce it to 10 days a month, and they spend all this time second guessing themselves, should I take it today or should I not take it today? Whereas if you just tell them blanket rule no, in a way, it kind of makes it easier for them. But yeah, certainly trying to get them through that first week can be difficult.
Now that looks like all the questions I've got listed here. Anyone else haven't got anything more there about the dry eye syndrome? I guess, is that something that you do see, Emma, that you see patients with headache sort of complaining of the dry eyes? Or not?
I haven't really heard about it, no, not really anything that I can think of there.
No, that's all right.
With the estrogen issue, I just wanted to point out that menopausal hormone therapy is a different situation to the oral contraceptive pill. Certainly, I think particularly with the transdermal estrogen preparations, they're certainly not a concern with migraine with aura. And certainly women with migraine then often flare up around the perimenopause, and so stabilising their estrogen levels can often be very helpful at that period of time.
Oh, thank you. That's very useful. So I'll give one more call out for questions. Just while you're perhaps thinking of them, you can probably see on the screen there that we've popped up the QR code for giving feedback on, the presentation and anything else you'd like to do, and particularly if anyone's got any other topics that we can drag Emma back for or get some other people to talk to us. Certainly like to thank you, Emma, for your time this evening. I think that was an excellent presentation that was very much geared towards sort of GPs and physios and people, primary care people, and hopefully might help us do a bit more before we refer them on to you.
Yeah, so certainly with the migraine patients in particular, certainly trying to get those preventive medications started early, and then certainly giving the preventive medications a proper go, and trying them out for a long enough period of time to see if they're going to have an effect is certainly a very helpful thing that you can do before they come to see me. And certainly having a list of which ones they've tried, and so I can see very quickly if they've tried the 3 or they've got contraindications to, and then they can start the new therapies, because certainly the patients are disappointed if they come along expecting me to give them Botox and they don't qualify for it on the PBS. So certainly it's useful to have started the preventives first.
Thank you. Thank you everyone else for attending, and
Yeah,
good
thank
night.
you
And
all.
stay
Yep.